Good afternoon, everyone. My name is Petra, and my PhD thesis title is Investigating Radioembolization as an Option in the Treatment of Liver Tumors. I'm a PhD student and a radiology clinician at the Medical Imaging Center, and my vision is that we will cure, not treat. And to achieve that, I would like to determine the efficacy and the safety of the isotopes used for radioembolization. I have two ongoing projects right now. My first project is about investigating the safety and efficacy of holmium radioembolization in the treatment of liver tumors. Liver tumors are a global health problem. However, only 30 to 50% of these tumors are suitable for definitive therapies. Therefore, there is a need for local regional treatment options. One of the local regional treatment options are transarterial radioembolization, and according to guidelines, there are scenarios when this is the best choice because it can be potentially curative. In the clinical use, we use two isotopes, yttrium and holmium. Holmium is a newer isotope and has some advantageous properties that yttrium does not have. Holmium is suitable for SPECT and MRI imaging and also can be used as a scout with a superior predictive value. There is a lot of evidence about using yttrium for treating liver tumors, but evidence on using holmium for this purpose needs to be more comprehensive. Therefore, our aim is to define the efficacy and the safety of holmium radioembolization. We would like to know that radioembolization using holmium isotopes is a safe and effective way of transarterial treatment in patients with liver tumors. And our primary outcome is tumor response, and our secondary outcomes are survival rates, toxicity, and quality of life. We conducted our systematic search in 5 databases with the following search key. And at the end of our selection, we've got 20 eligible full articles. We finished analyzing the main outcome and most of the secondary outcomes as well. Okay, so for the evaluation of tumor response, we have 2 systems, and the RECIST one measures the whole tumor size, including the dead necrotic part as well, whereas the modified RECIST system measures only the viable living part of the tumor. So our primary outcome is tumor response, and we express tumor response in terms of disease control rate, which refers to how successful we were in preventing the tumors from growing, the living tumors from growing, and that's why modified RECIST, which measures only the living part of the tumors, is more relevant to us. Here you can see my primary outcome. Proportions refer to the ratio of patients whose tumors were under control by holmium therapy. For both systems, we have 5 studies each, covering nearly 100 patients in both cases, and these are all mixed observational studies. The between study heterogeneity was considered severe in both cases, probably because of these are all mixed observational trials. So according to RECIST, nearly half of the patients had their tumors under control, but according to modified RECIST, more than 90% of the patients had their tumors under control. And since we know that modified RECIST is more sensitive, it clearly indicates that holmium therapy was effective. And this outcome suggests that holmium works for the actually clinically relevant outcome, which is the rate of the tumors that we could prevent from growing. Here you can see the disease control rate at 6 months follow-up, and you can see that disease control rate was higher, measured with modified RECIST as well, and according to that, holmium therapy was effective in controlling the tumors from growing even after 6 months. Okay, so our next outcome is overall survival rate at 3 and 6 monthly follow-up times. Here you can see the difference between our current study with holmium and the yttrium meta-analysis in the literature. I highlighted the time frames where holmium performed better, and it indicates a positive signal that holmium is safe and beneficial. Here you can see the individual forest plots from our study at different follow-up times. And I would like to draw your attention to the size of the diamond. And as you can see, the uncertainty increases as the follow-up time increases, and that indicates a clear need for well-designed long-term follow-up observation, long-term follow-up clinical trials, and in the second project we would like to do that. Our next outcome is severe clinical adverse events defined by the CTCAE criteria. And as you can see, the diamond is close to 0 in every cases, indicating that holmium therapy was safe. Our next outcome is laboratory adverse events, and we observed two severe changes in two laboratory parameters. One increase in the GGT levels and the development of lymphocytopenia. And these parameters need to be better discussed in the literature, and in our second study we would like to investigate it as well. As you can see, other severe laboratory adverse events were almost non-existent. Our last outcome is tumor absorbed dose and healthy liver absorbed dose. So a high tumor absorbed dose increases the likelihood of killing the tumor cells efficiently, but limiting the healthy liver absorbed dose is crucial in preventing radioembolization-induced liver disease and other complications. So in our study, tumor absorbed dose was 4 times higher than healthy liver absorbed dose, which indicates that holmium therapy was not only effective but safe because the healthy liver can handle up to 60 gray without failure. So the strength of our study that it clearly answers the research question with sound methodology, and it enables the subsequent clinical trial with clearly defined parameters. We have some limitations, that these were only observational studies that we included, and the outdated technologies used in previous publications limit the applicability and generalizability. We conclude that holmium radioembolization can control liver tumor growth efficiently without major complications. Our implication for practice is that holmium radioembolization seems to be a good treatment option in unresecable malignant liver tumors, and our implication for research is that holmium radioembolization needs to be compared to the currently available treatment options, such as yttrium radioembolization. Here you can see the progress of my first project. We started drafting the manuscript, and we finished the methods and the results part. My second project is an RCT about comparing the use of holmium and yttrium isotope in transarterial radioembolization for the treatment of liver tumors. So as I mentioned before, local regional treatment options include radioembolization, which has 2 isotopes in the clinical use, and these isotopes have different characteristics, but their safety and efficacy in different tumor types and different populations are not yet fully understood. So our aim is to determine if holmium has different safety and efficacy than yttrium. So now we know that holmium is safe, so it's time to conduct our first RCT. We would like to include patients with hepatocellular carcinoma, which is a more current patient population. We would like to compare holmium to yttrium to answer the reliable remaining questions, and to enable protocolization of holmium. And our outcomes are the same as our meta-analysis. So here you can see our inclusion and exclusion criteria for the study, our interventions, radioembolization with holmium and yttrium, and our outcomes, which are the same as our meta-analysis. So in conclusion, to sum it up, we have 2 ongoing projects right now, and would like to finish it by the end of August and September. And I would like to thank you for your attention with a quote: "Man can learn nothing except by going from the known to the unknown." Thank you.
Thank you very much for the nice presentation. I got one question. Do you apply this therapy only for the primary liver tumors or for the metastasis as well?
For the metastasis as well, in the meta-analysis, because we didn't have enough data only from the primary liver tumors. If we could, it would be better, but we had to include the metastasis as well.
Okay, thank you.
Thank you for your presentation. What do you think, what is the cause of the elevation of the gamma GT in your results and lymphocytopenia? Do you have any guess?
Yeah, so this is not well discussed in the literature, but there are some theories. So one theory is that radioembolization sometimes obstructs the bile ducts and irritates bile ducts for a limited time. And then, because of this, it can increase the GGT levels, and also the GGT levels increase when the liver gets some stress. And the radioembolization also makes some stress to the liver, and this is why GGT increases, I think, in our theories.